Acute abdominal pain. Frederick H. Millam. 11. Acute abdominal pain is a frequent complaint that causes patients to visit an emergency department. In 2014, 11.1 million emergency department visits in the USA were due to abdominal pain, accounting for 8% of all emergency department visits that year. 1. Approximately 40% of these patients have nonspecific findings. 2,3 of the remainder in whom a specific diagnosis is ascertainable. Most causes are surgical disorders that warrant further evaluation and intervention. 3. In a small number, life-threatening pathologies are present. Therefore, the evaluation of acute abdominal pain must be efficient and lead to an accurate diagnosis soon after presentation so that the treatment of patients who are seriously ill is not delayed and resources are not overutilized on patients with a self-limited disorder. Anatomy and physiology. A number of physiologic factors determine how abdominal pain is perceived. These include the nature of the stimulus, type of neuroreceptor involved, anatomy of the neural pathways from the site of injury to the CNS, and interaction of modifying influences on the transmission, interpretation, and reaction to pain messages. 4. Pain resulting from abdominal pathology is transduced in different ways by sensory afferent fibers that travel with the autonomic and somatic nervous systems. 5. 6. These two systems transduce pain in different ways, leading to different nociceptive sensations. Crosstalk between the two systems can result in yet more variation in the perception of abdominal distress. 6. This unique neuroanatomy results in 3 distinct types of pain: visceral, somatic, parietal, and referred. Visceral pain is usually vague in both onset and localization and perceived as a dull sensation in the abdominal midline. Somatic parietal pain is more intense, sharp, and well localized. Referred pain is perceived at a point distant from the inciting pathology and may be perceived to be outside the abdomen entirely. Sensory neuroreceptors in abdominal organs are located in the mucosa and muscularis of hollow viscera, on serosal structures such as the peritoneum, and within the mesentery, Fig. 11.1.6. In addition to nociception, the perception of noxious stimuli, sensory neuroreceptors are involved in the regulation of secretion, motility, and blood flow via local and central reflex arcs. 7. Although sensory information conveyed in this manner is not usually perceived, disordered regulation of these GI functions, secretion, motility, blood flow, can cause pain. For example, patients with IBS perceive pain as a result of heightened sensitivity of intestinal afferent neurons to normal endogenous stimuli that results in altered intestinal motility and secretion. See Chapter 122.8. Visceral pain. The abdominal viscera are innervated by two systems: vagal afferent nerves and spinal visceral sensory nerves. 6. Spinal visceral afferent nerves are further specified as splanchnic nerves that follow sympathetic efferent pathways and pelvic visceral afferent nerves that run with parasympathetic efferent pathways. Fig. 11.2.6. Spinal visceral nerves, also known as splanchnic nerves, innervate all layers of the intestinal wall, including the serosa and the mesentery. These nerves are composed predominantly of unmyelinated C fibers, although a small number of fine, myelinated A delta fibers are also present. 9. Visceral pain is transduced at its source by bare nerve endings that lack the specialized structures such as capsules found in somatic nerve endings. Neurophysiologic studies have identified 4 distinct types of visceral sensory nerves: chemonociceptors found in the mucosa, tonic mechanoreceptors, high-threshold mechanoreceptors, and so-called silent nociceptors. 6. 9. Mucosal chemonociceptors are sensitive to noxious luminal contents. Tonic mechanoreceptors, also known as wide-range receptors, have relatively high levels of resting activity and respond to rising wall tension with a linear increase in activity. High-threshold mechanoreceptors, also known as phasic part 3 symptoms, signs, and biopsychosocial issues receptors, have low resting activity and respond to excessive mechanical distension only. 6. Silent nociceptors are activated only in the presence of inflammatory mediators. 9. High threshold receptors are thought to transduce pain from organs like the ureter and kidney, for which pain is the only sensation perceived consciously, whereas organs like the bladder and stomach, from which non-noxious as well as noxious sensations are perceived consciously, are innervated by both tonic and high threshold receptors. 10 Spinal splanchnic nerves have wide afferent distribution in the spinal cord through laminae I, 2, V, and X. 64 Anatomic factors contribute to the poor localization of visceral pain and the phenomenon of referred pain to areas distant from its origin. First, spinal splanchnic afferents are spread across a broad range of dorsal root ganglia. The dispersal of painful input at the level of the spinal cord leads to poor anatomic discrimination. Second, spinal afferents have a more generalized and overlapping viscerotopic distribution and enter the spinal cord bilaterally. This lack of side specificity leads to localization of visceral pain in the midline, Fig. 11.3. Third, the ratio of afferent fibers to cell bodies in the dorsal root ganglia is low, and fourth, there is considerable convergence, or crosstalk, between the visceral afferents and the somatic pain neurons in the dorsal horn of the spinal cord. Therefore, visceral pain is often vaguely assigned to a broad topologic area. Crosstalk within the spinal cord between spinal visceral afferents fibers and somatic parietal fibers that originate in distant body areas can create the perception of pain in a distant location, or referred pain, see later. In contrast to the spinal splanchnic afferent sensory system, vagal visceral afferents primarily convey non-noxious stimuli, such as satiety. 6 Pain from the abdominal viscera is primarily the result of stretch and distension transduced by mechanoreceptors and, in more severe situations, the presence of inflammatory mediators detected by the silent nerve endings. Cutting and burning of abdominal viscera is not perceived as noxious. These properties explain why gaseous distension during colonoscopy is frequently painful, but polypectomy is not. Once the visceral pain-sensing neurons enter the CNS, they project not only to midbrain medulla vagus nerve T1 superior cervical ganglion superior mesenteric ganglion inferior mesenteric ganglion pelvic nerves L1 S1 reproductive organs bladder kidney colon small intestine adrenal pancreas liver bile ducts abdominal blood vessels stomach esophagus bronchi lungs trachea larynx heart C1 celiac ganglion Fig. 11.2 Pathways of visceral sensory innervation. The visceral afferent fibers that mediate pain travel with autonomic nerves to communicate with the central nervous system. In the abdomen, these fibers include the vagal and pelvic parasympathetic nerves and thoracolumbar sympathetic nerves. Sympathetic fibers, red lines, parasympathetics, blue lines. Spinal cord levels, C, cervical, L, lumbar, S, sacral, T, thoracic. Chapter 11 Acute Abdominal Pain 147-11 The somatosensory cortex as part of the lateral pain system, which assigns the signal a location and intensity, but also to the cingulate gyrus as part of the medial pain system, which influences affective behavior, see Chapter 12.6 Somatic parietal pain. Somatic parietal pain is mediated by A-delta fibers that are distributed principally to skin and muscle. Signals from this neural pathway are perceived as sharp, sudden, well-localized pain, such as that which follows an acute injury. These fibers convey pain sensations through somatic spinal nerves. Stimulation of these fibers activates local regulatory reflexes mediated by the enteric nervous system and long spinal reflexes mediated by the autonomic nervous system, in addition to transmitting pain sensation to the CNS. 11 Somatic parietal pain arising from noxious stimulation of the parietal peritoneum is more intense and more precisely localized than visceral pain. An example of this difference occurs in acute appendicitis, in which early vague periumbilical visceral pain originating within the appendix is followed by localized somatic parietal pain at McBurney's point that is produced by inflammatory involvement of the parietal peritoneum adjacent to the appendix. Somatic parietal abdominal pain is usually aggravated by movement or vibration. The nerve impulses that mediate such pain travel in somatic sensory spinal nerves that correspond to the cutaneous dermatomes of the skin from the 6th thoracic, T6, to 1st lumbar, L1, vertebral segment. Because these nerve fibers do not cross the midline at the spinal cord, lateralization of parietal pain is much more precise than in visceral pain. Reflexive responses, e.g., involuntary guarding, abdominal rigidity, are mediated by spinal reflex arcs involving somatic parietal pain pathways. Afferent pain impulses are modified by inhibitory mechanisms at the level of the spinal cord. Somatic A delta fibers mediate touch, vibration, and proprioception in a dermatomal distribution that matches the visceral innervation of the injured viscera and synapse with inhibitory interneurons of the substantia gelatinosa in the spinal cord. In addition, inhibitory neurons that originate in the mesencephalon, periventricular gray matter, and caudate nucleus descend within the spinal cord to modulate afferent pain pathways. These inhibitory mechanisms allow cerebral influences to modify afferent pain impulses. See Chapter 12.12 Referred pain. Referred pain is felt in areas remote from the diseased organ and results when visceral afferent neurons and somatic afferent neurons from a different anatomic region converge on second-order neurons in the spinal cord at the same spinal segment. This convergence may result from the innervation, early in embryologic development, of adjacent structures that subsequently migrate away from each other. As such, referred pain can be understood to refer to an earlier developmental state, e.g., the central tendon of the diaphragm begins its development in the neck and moves cranio-caudad, bringing its innervation, the phrenic nerve, with it. Fig 11.4 shows how diaphragmatic irritation from a subphrenic hematoma or splenic rupture may be perceived as shoulder pain. Care sign. Point 13 Evaluation. Effective evaluation of a patient with acute abdominal pain requires careful but expeditious history-taking and physical examination, often repeated serially, and, in many cases, informed use of imaging studies. When a carefully performed history and physical examination are paired with appropriate and timely imaging, an accurate diagnosis can often be determined relatively quickly. Inadequate clinical evaluation or poor selection of imaging methods leads to unnecessary delay, often resulting in a poor outcome. Common entities like appendicitis, cholecystitis, and diverticulitis can be diagnosed with almost complete accuracy. Patients with other diseases require an orderly and efficient evaluation and judicious selection of imaging studies. 1122A33 Fig 11.3 Localization of visceral pain. Pain arising from organ areas depicted in 1, 2, and 3 is felt in the epigastrium, midabdomen, and hypogastrium, respectively, as shown in A. The arrow in A indicates biliary pain that is referred to the right scapular area. To brain spinal cord CBA visceral afferent first-order neuron spinal cord second-order neuron somatic afferent first-order neuron ABC Fig 11.4 The neuroanatomic basis of referred pain. Visceral afferent fibers that innervate the diaphragm can be stimulated by local irritation, e.g., subdiaphragmatic abscess circle. These visceral afferent fibers, A, synapse with second-order neurons in the spinal cord, B, as well as somatic afferent fibers, C, arising from the left shoulder area, cervical roots 3 to 5. The brain interprets the pain to be somatic in origin and localizes it to the shoulder. 148 Part 3 Symptoms, Signs, and Biopsychosocial Issues. Approach to acute care. Abdominal pain can be the presenting symptom of a life-threatening abdominal catastrophe, acute abdomen. Therefore, when approaching a patient with acute abdominal pain, the physician should begin with a rapid assessment of the patient's overall physiologic state, looking for clues that the patient is in shock or on the precipice of hemodynamic instability. Quickly identifying patients who are unstable or in shock is essential to expedite treatment and improve the likelihood of a satisfactory outcome. Shock is suggested by pallor, cyanosis, mottling, prostration, hypotension, tachycardia, or other signs of hypoperfusion, such as tachycardia, tachypnea, and presence of a metabolic acidosis. In addition to vital sign changes such as tachycardia and hypotension, the evaluation of patients with acute abdominal pain should include assessment of organ perfusion, specifically serum lactate, platelet count, serum bilirubin, Glasgow Coma Scale, and serum creatinine. The Sequential Organ Failure Assessment, or SOFA, score, Table 11.1, is a useful tool to assess the presence of the systemic inflammatory response seen in early SEP.14 in the setting of acute abdominal pain. A SOFA score greater than or equal to 2, serum lactate levels of greater than 2, or a requirement for vasopressor support defines patients with septic shock. If hemodynamic instability is apparent, including clinical evidence of shock, surgical consultation should be sought immediately, and consideration should be given to endotracheal intubation and aggressive hemodynamic resuscitation early in the encounter. The adage in acute care surgery that death begins in radiology is a reminder that hemodynamic resuscitation should be initiated prior to diagnostic imaging. History in the timeless treatise on abdominal pain bearing his name, first published in 1921, Sir Zachary Cope tells us, it can be confidently asserted that a large number, if not the majority, of acute abdominal conditions could be diagnosed by considering carefully the history of onset. 15 Despite the advances made in clinical imaging in the centuries since then, history taking remains the most important component of the initial evaluation of the patient with acute abdominal pain. Characteristic features of pain associated with various common causes of acute abdominal pain are shown in Table 11.2. Attention to these features can lead to a rapid clinical diagnosis or exclusion of important diseases in the differential diagnosis, thereby enhancing the reliability and effectiveness of subsequent diagnostic testing. For example, plain abdominal films are most efficacious when limited to patients with symptoms of intestinal obstruction. 16 Table 11.2 Comparison of common causes of acute abdominal pain: cause, onset, location, character descriptor, radiation intensity, appendicitis, gradual peri-umbilical area, early, RLQ, late, diffuse, early, localized, later, aching, none, plus cholecystitis, acute mid-epigastrium, RUQ, right scapula, localized, constricting scapula, plus pancreatitis, acute epigastrium, T10L2, area of the back, localized, boring, mid-back, plus to diverticulitis, gradual, LLQ, localized, aching, none, plus to perforated peptic ulcer, sudden epigastrium, localized, early, diffuse, later, burning, none, plus SBO, gradual peri-umbilical area, diffuse cramping, none, plus mesenteric ischemia, infarction, sudden peri-umbilical area, diffuse agonizing, none, plus ruptured abdominal aortic aneurysm, sudden abdomen, back, flank, diffuse tearing, none, plus gastroenteritis, gradual peri-umbilical area, diffuse spasmodic, none, and 2 plus pelvic inflammatory disease, gradual, either LQ, pelvis, localized, aching, upper thigh, plus ruptured ectopic pregnancy, sudden, either LQ, pelvis, localized, sharp, none, plus mild, moderate, severe, LQ, lower quadrant. Table 11.1 Sequential organ failure, SOFA, score 1 2 3 4 organ system units, respiratory POW 2/FiO2 mmHg 400 300 200 *100 coagulation platelets 000/mm3 150 150 20 liver bilirubin mg/dl 1.2 to 1.9 2.0 to 5.96.0 to 11.9 greater than or equal to 12 mol/L 20 to 32 33 to 101 102 to 204 greater than 204 CNS Glasgow Coma Scale 13 to 14 10 to 12 6 to 9 6 renal creatinine mg/dl 1.2 to 1.9 2.0 to 3.4 3.5 to 4.9 greater than 5 mol/L 110 to 170 171 to 299 300 to 440 greater than 440 urine output ml/day 500 200 or requiring respiratory support. SOFA score equals sum of individual organ system scores. Sepsis should be suspected if the SOFA score is greater than 2 in the setting of acute abdominal pain. Septic shock is defined as a SOFA score greater than 2 and serum lactate level greater than 2 mol/L, or if a vasopressor is required in the setting of infection. Adapted from Singer M., Deutschmann C.S., Seymour C.W., et.al. The Third International Consensus Definitions for Sepsis and Septic Shock, Sepsis 3. JAMA 2016, 315:80110. Chapter 11 Acute Abdominal Pain 149 11 Chronology. The time courses of several common causes of acute abdominal pain are diagrammed in Fig 11.5. The rapidity of onset of pain is often a measure of the severity of the underlying disorder. Pain that is sudden in onset, severe, and generalized is likely to be the result of an intra-abdominal catastrophe such as a perforated viscus, mesenteric infarction, or ruptured aneurysm. Affected patients usually recall the exact moment of onset of their pain. Progression is an important temporal factor in abdominal pain. In some disorders, e.g., gastroenteritis, pain is self-limited, whereas in others, e.g., appendicitis, pain is progressive. Pain associated with obstruction has a repeating crescendo-decrescendo pattern that may be diagnostic, particularly when it occurs in association with nausea and vomiting. The duration of abdominal pain is also important. Patients who seek evaluation of abdominal pain that has been present for an extended period, e.g., weeks, are less likely to have an acute life-threatening illness than patients who present within hours to days of the onset of their symptoms. Location. The location of abdominal pain provides a clue to interpreting the cause. As noted earlier, a given noxious stimulus may result in a combination of visceral, somatic, parietal, and referred pain, thereby creating confusion in interpretation unless the neuroanatomic pathways are considered. For example, the pain of diaphragmatic irritation from a left-sided subphrenic abscess may be referred to the shoulder and misinterpreted as pain from ischemic heart disease, see Fig 11.4. Pain radiating to the back from pancreatic or biliary pathology may be conflated with musculoskeletal processes, thereby delaying treatment. Changes in location may represent progression from visceral to localized parietal peritoneal irritation, as with appendicitis, or represent development of diffuse peritoneal irritation, as with a perforated ulcer. Intensity and character. Acute abdominal pain usually follows one of three patterns. Pain that is prostrating and physically incapacitates the sufferer is usually due to a severe life-threatening disease like a perforated viscus, ruptured aneurysm, or severe pancreatitis. By contrast, patients with obstruction of a hollow viscus, as in intestinal obstruction, renal colic, or biliary pain, present with gradual onset of cramping pain that follows a sinusoidal pattern of intense pain alternating with a period of relief. Nausea and vomiting are characteristic symptoms associated with this group of disorders. The obstructed viscus need not be the intestine for nausea or vomiting to occur, as in the case of a kidney stone. The third pattern is of gradually increasing discomfort, usually vague and poorly localized at the start but becoming more localized as the pain intensifies. This picture is usually due to inflammation, as with acute appendicitis or diverticulitis. Some disorders, such as acute cholecystitis, may start out as colicky pain but evolve into a constant pain as cystic duct obstruction leads to gallbladder inflammation. The clinician should be cautious in assigning too much importance to a patient's description of the pain. Exceptions are common, and a given descriptor may be attributable to a number of conditions. Symptoms in the elderly can be subtle despite the presence of life-threatening pathology, making this group particularly challenging. Aggravating and alleviating factors. The relationship of pain to positional changes, meals, bowel movements, and stress may yield important diagnostic clues. Patients with peritonitis lie motionless, whereas those with renal colic may writhe in an attempt to find a comfortable position. Sometimes, certain foods exacerbate pain. A classic example is the relationship between the intake of fatty foods and development of biliary pain. Pain associated with duodenal ulcer is often alleviated by meals. By contrast, patients with gastric ulcer or chronic mesenteric ischemia may report exacerbation of pain with eating. Patients often self-medicate to alleviate symptoms. A history of chronic antacid or NSAID use, for example, may suggest the presence of PUD. This is a growing consideration as patients and physicians increasingly rely on NSAIDs as alternatives to opioids for chronic pain. Associated symptoms. Information regarding changes in constitutional symptoms, e.g., fever, chills, night sweats, weight loss, myalgias, arthralgias, digestive function, e.g., anorexia, nausea, vomiting, flatulence, diarrhea, constipation, jaundice, dysuria, changes in menstruation, and pregnancy should be solicited from the patient. A careful review of these symptoms may reveal important diagnostic information. Clear vomitus suggests gastric outlet obstruction, whereas feculent vomitus suggests more distal small bowel or colonic obstruction. A constellation of findings may indicate a particular disease entity. Past medical history. A careful review of the patient's other medical problems often sheds light on the presentation of acute abdominal pain. Previous experience with similar symptoms suggests a recurrent problem. Patients with a history of partial SBO, renal calculi, or pelvic inflammatory disease are likely to have recurrences. A patient whose presentation suggests intestinal obstruction, and who has no prior surgical history, deserves special attention because of the likelihood of surgical pathology such as a hernia or neoplasm. Patients with a systemic illness, such as scleroderma, SLE, nephrotic syndrome, porphyria, or sickle cell disease, often have abdominal pain as a manifestation of the underlying disorder. Abdominal pain may also arise as a side effect of a medication taken for another disease. Severity BCA time D Fig 11.5 Patterns of acute abdominal pain. A. Many causes of abdominal pain subside spontaneously with time, e.g., gastroenteritis. B. Some pain is colicky, i.e., the pain progresses and remits over time. Examples include intestinal, renal, and biliary pain, colic. The time course may vary widely from minutes in intestinal and renal pain to days, weeks, or even months in biliary pain. C. Commonly, acute abdominal pain is progressive, as in acute appendicitis or diverticulitis. D. Certain conditions have a catastrophic onset, such as a ruptured abdominal aortic aneurysm. 150 Part 3 Symptoms, Signs, and Biopsychosocial Issues. Physical examination. The physical examination of the patient with acute abdominal pain begins with an assessment of the patient's appearance and assessment for signs of sepsis or shock, as described earlier. The patient's ability to converse, breathing pattern, position in bed, posture, degree of discomfort, and facial expression should be noted. A patient lying still in bed in the fetal position and reluctant to move or speak, with a distressed facial expression, is likely to have peritonitis. A patient who writhes and frequently changes position has purely visceral pain, as in intestinal obstruction or gastroenteritis. Tachypnea may be a sign of metabolic acidosis caused by shock. Atrial fibrillation noted on physical examination or an electrocardiogram may suggest mesenteric arterial embolus. All patients should undergo a careful systematic examination regardless of the differential diagnosis suggested by the history. Abdominal examination. Examination of the abdomen is central to evaluating a patient with acute abdominal pain and should begin with careful inspection. The entire abdomen, from the nipple line to the thighs, should be exposed. Obese patients should be asked whether the degree of protrusion of the abdominal wall is greater than usual. Asthenic patients may feel themselves to be distended but have relatively little apparent abdominal protrusion. Assessment for the presence of bowel sounds and their character should precede any maneuvers that will disturb the abdominal contents. Before concluding that an abdomen is silent, the examiner should listen for at least 2 minutes and in more than one quadrant of the abdomen. Experienced listeners may distinguish the high-pitched churning of a mechanical SBO from the more hollow sounds of toxic megacolon, like dripping in a cavern. Nevertheless, some studies have cast doubt on the reliability of bowel sound assessment in patients with SBO and other conditions. 17 And clinicians should avoid basing clinical decisions too heavily on assessment of bowel sounds. Auscultation may, however, be a good way to assess tenderness. When listening with the stethoscope, the astute clinician may begin to palpate the abdomen with the head of the stethoscope while carefully watching the patient's facial expression. If tenderness is detected, an assessment for rebound tenderness should be carried out next to look for evidence of peritonitis. Rebound tenderness may be elicited by jarring the patient's bed or stretcher or by finger percussion. Palpation is performed next. If pain is emanating from one particular region, that area should be palpated last to detect involuntary guarding and muscular rigidity. Patients with a rigid abdomen rarely reveal any additional findings, e.g., a mass, on physical examination. Because these patients usually have a surgical emergency, abdominal examination can be done more completely once the patient is under anesthesia, just before laparotomy. Genital, rectal, and pelvic examinations. The pelvic organs and external genitalia should be examined in every patient with acute abdominal pain. The rectum and vagina provide additional avenues for gentle palpation of pelvic viscera. Gynecologic pathology should be excluded in all women with acute abdominal pain. Laboratory data. The history and physical examination findings generally are not sufficient to establish a firm diagnosis in a patient with acute abdominal pain. All patients with acute abdominal pain should have a CBC, with a differential count, and urinalysis. Determination of serum electrolyte, blood urea nitrogen, creatinine, and glucose levels is useful for assessing the patient's fluid and acid-base status, renal function, and metabolic state, and should be done for every patient with acute abdominal pain who presents to an emergency department. Urine or serum pregnancy testing must be performed in all women of reproductive age with abdominal pain. Liver biochemical tests and serum amylase or lipase levels should be ordered for patients with upper abdominal pain or with jaundice. Leukocytosis, particularly when associated with band forms, is an important finding. Metabolic acidosis, an elevated serum lactate level, or depressed bicarbonate levels are associated with tissue hypoperfusion and shock. Patients who manifest these findings are likely to require urgent surgical intervention or intensive care. Imaging studies. CT. The development of high-speed helical CT has revolutionized the evaluation of acute abdominal pain. In many conditions, such as appendicitis, CT can almost eliminate diagnostic uncertainty. In the pre-CT era, history-taking and physical examination alone had a specificity of approximately 80%. By contrast, the sensitivity and specificity of CT for acute appendicitis are 94% and 95%, respectively. A negative CT in the setting of acute abdominal pain has considerable value in excluding common disorders. The question arises as to whether CT should be a standard part of the evaluation in all patients with acute abdominal pain. Several arguments against routine CT have been raised. 18 First, CT can be performed in a number of ways, and the most efficacious method must be chosen in any given clinical setting. For example, a patient with suspected renal colic should have a limited, non-contrast enhanced, renal calculus protocol CT. Obtaining a standard oral and 4-contrast CT in this case may obfuscate rather than illuminate the pathology. Alternatively, a patient in whom arterial occlusive disease is suspected should undergo CT arteriography using a bolus 4-contrast technique. A radiologist should be consulted regarding selection of the most appropriate CT study in a given patient. Second, some diseases, such as acute cholecystitis and cholangitis, are not optimally imaged by CT. A patient with RUQ pain who is suspected of having either of these diagnoses should undergo a US of the RUQ as the primary diagnostic test. Third, as noted earlier, a patient who is unstable or exhibits signs of shock should be evaluated by a surgeon before any imaging study is considered. In a patient with suspected trauma or hemiperitoneum, the focused abdominal sonogram for trauma, FAST, see later, which can be done at the bedside in the emergency department, is a preferable approach. The presence of shock and fluid in the abdomen is an indication for immediate laparotomy, and further diagnostic maneuvers, including CT, add little value to the patient's care. A final consideration regarding the role of CT in evaluating acute abdominal pain is radiation exposure. Particularly for patients younger than 35 years of age and those who have required multiple examinations, abdominal CT may increase the lifetime risk of cancer. 18 Additionally, unless a life-threatening condition is suspected, CT is best avoided in a pregnant patient, in whom MRI is a suitable alternative. 19 US FAST is a rapid, reliable, bedside test to detect fluid in the abdominal cavity. Although its main usefulness is for the evaluation of injured persons, this examination also aids in the diagnosis of any condition that results in free intraperitoneal fluid. Chapter 11 Acute Abdominal Pain 151-11 Imaging of the aorta can be added, allowing a rapid assessment for aortic aneurysm. Point-of-care abdominal US has become a routine and highly reliable part of the evaluation of acute abdominal pain. 20 Other diagnostic tests. Other diagnostic imaging modalities like MRI and radionuclide scanning, e.g., 99 MTC labeled hydroxyl imidodiacetic acid HITA scan, and endoscopy usually take a secondary role in the evaluation of the patient with acute abdominal pain. Use of these tests is generally guided by the results of CT or US. Angiography may be useful not only for establishing a diagnosis of visceral ischemia but also for delivering therapy aimed at improving or re-establishing blood flow. Diagnostic peritoneal lavage, although seldom used now, is useful when a patient is too unstable from a cardiopulmonary standpoint to tolerate imaging studies. The finding of leukocytes in the lavage effluent in an unstable patient may, in extreme circumstances, constitute sufficient grounds for laparotomy. In a patient who is unstable and deteriorating and has signs of an acute abdomen, laparotomy as a diagnostic maneuver should be considered if imaging is considered prohibitively risky. An overall approach to the patient with acute abdominal pain is illustrated in Fig. 11.6. Causes acute abdominal pain is usually defined as pain of less than 1 week in duration. Patients usually seek attention within the first 24 to 48 hours, although some may endure longer periods of abdominal discomfort. The most common reason for a patient to seek emergency department evaluation of abdominal pain is so-called nonspecific abdominal pain. Between 25% and 50% of all patients who visit an emergency department for abdominal pain will have no specific disease identified. The distribution of the causes of abdominal pain in patients who present to an emergency department is shown in Table 11.3. Acute appendicitis. Acute appendicitis is a ubiquitous problem, accounting for approximately 5% of all emergency department visits for patients under 65 years of age E21 and 30% of acute surgical abdominal emergencies in patients under 50 years of age worldwide. 22 Appendicitis accounted for 318,000 hospital admissions in the USA in 2006,23 and has an overall incidence of approximately 82 to 110/100,000 population in North America. 24 The lifetime risk of appendicitis is 8.6% for males and 6.7% for females in Western countries. 25 and may be twice this risk in Asia. 26 Acute abdominal pain, prostration, shock or hemodynamic instability, resuscitation, urgent surgical evaluation, consider fast examination, consider laparotomy, perforated viscous severe pancreatitis, ruptured spleen, ruptured AAA. Acute appendicitis, ovarian torsion, ectopic pregnancy, cholelithiasis, cholecystitis, bile duct obstruction, cholangitis, SBO, discharge with 24 to 48 HR. Follow-up. Alvarado score less than or equal to 4, Alvarado score greater than or equal to 5, appendix protocol, MRI, upright abdominal film, SBO protocol, oral contrast CT, upright abdominal film, oral contrast CT, appendix protocol, CT, age 20, pregnancy, RLQ US, RUQ US, no, yes, 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 no, 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 RLQ, pain/tenderness, localized guarding, gradual onset, RUQ, pain, history of postprandial discomfort, nausea, vomiting, obstipation, constipation, abdominal distension, prior abdominal surgery, sudden onset, diffuse pain, involuntary guarding, rebound tenderness, peritonitis. Evaluation. Most likely diagnoses: perforated viscous diverticulitis, mesenteric infarction, acute pancreatitis. Fig. 11.6 An approach to the urgent evaluation of abdominal pain. Specific complaints and physical examination findings are coupled with appropriate imaging. For LLQ pain, the most likely diagnosis is diverticulitis. AAA, abdominal aortic aneurysm, ABC, airway, breathing, circulation, fast, focused abdominal sonogram for trauma. 152 Part 3 Symptoms, Signs, and Biopsychosocial Issues. Typically, acute appendicitis begins with prodromal symptoms of anorexia, nausea, and vague periumbilical pain. Within 6 to 8 hours, the pain migrates to the right lower quadrant and peritoneal signs develop. In uncomplicated appendicitis, a low-grade fever to 38 degrees Celsius and mild leukocytosis are usually present. A higher temperature and WBC count are associated with perforation and abscess formation. Common features of the history, physical examination, and WBC count in patients with appendicitis have been combined into a predictive tool known as the Alvarado score. Table 11.4.27 For men, a score of 4 or less accurately excludes appendicitis, the score is less useful in women and children. 28 Atypical presentations of acute appendicitis, however, are common, and a diagnosis of acute appendicitis should not be rejected simply on the basis of the patient's history and physical examination alone. An appendicitis inflammatory response score has also been proposed. 29 In children, mesenteric adenitis, or lymphadenitis, is frequently mistaken for acute appendicitis but is often preceded by a sore throat and is self-limited. Mesenteric adenitis may also be caused by Yersinia enterocollitica, see Chapter 110. Whereas plain abdominal films are not diagnostic and have little role in the diagnosis of acute appendicitis, CT has dramatically improved the accuracy of diagnosis in patients with acute appendicitis. An appendix diameter greater than 10 mm is generally considered diagnostic of appendicitis, although the normal range for the diameter of the appendix may extend to nearly 13 mm. 30 other CT signs of acute appendicitis include periappendiceal fat inflammation, presence of fluid in the RLQ, and failure of contrast dye to fill the appendix. 31 The addition of CT has reduced the negative appendectomy rate to about 5%. 32 Because CT entails radiation exposure. 18 Some authorities advocate avoiding CT in children and adolescents. 33 In whom a higher degree of diagnostic uncertainty is tolerated in favor of lower radiation exposure, see Chapter 120. In this setting, US of the appendix has a sensitivity of 0.86 and specificity of 0.81 for detecting acute appendicitis. 34 In a pregnant patient in whom radiation exposure is also a significant concern, MRI has become the imaging method of choice, with the sensitivity and specificity approaching those of CT. 35 Acute biliary disease. Biliary disease accounts for approximately 7% of visits to an emergency department for abdominal pain and 14% to 21% of admissions for patients over 65 years of age. 21, 22 affected patients generally present at some point on the spectrum between biliary pain, biliary colic, and acute cholecystitis. Biliary pain is a syndrome of RUQ or epigastric pain, usually postprandial, caused by transient obstruction of the cystic duct by a gallstone. It is self-limited, generally lasting less than 6 hours. Acute cholecystitis is, in most cases, caused by persistent obstruction of the cystic duct by a gallstone. The pain of acute cholecystitis is almost indistinguishable from that of biliary pain, except that it is persistent. The pain usually is a dull ache that is localized to the RUQ or epigastrium with radiation around the back to the right scapula. Nausea, vomiting, and low-grade fever are common. On examination, RUQ tenderness, guarding, and Murphy sign, inspiratory arrest on palpation of the RUQ, are typical. The WBC count is usually mildly elevated but may be normal. Mild elevations in serum total bilirubin and alkaline phosphatase levels are common. The role of gallstones in the etiology of biliary pain and acute cholecystitis makes US of the RUQ the key diagnostic test. Demonstration of gallstones may suggest biliary pain, whereas the finding of stones with gallbladder wall thickening, pericholecystic fluid, and pain on compression of the gallbladder with the ultrasound probe, sonographic Murphy sign, is essentially diagnostic of acute cholecystitis and has replaced hepatobiliary scintigraphy, e.g., HITA scan, in the diagnosis of acute cholecystitis. 36 US, while sensitive for the presence of stones, has been found to have poorer sensitivity, 73.4%, and specificity, 85.5%, for the detection of acute cholecystitis. 37 Consideration of imaging findings in the context of the physical examination and laboratory findings is essential for accurate diagnosis. The Tokyo Consensus criteria for the diagnosis of acute cholecystitis are shown in Table 11.5. Patients with acute cholecystitis are best managed with cholecystectomy within 48 hours. 38-39 Patients who are older and tachycardic and have ultrasonographic evidence of gallbladder wall thickening, particularly those with a WBC count greater than 13,000/mm3, are at higher risk for gangrenous cholecystitis and generally require emergent open cholecystectomy. 40,41 Patients who present with RUQ pain, jaundice, and signs of sepsis should be suspected of having obstruction of the bile duct by a gallstone. RUQ pain, fever, and chills, and jaundice, Charcot triad, are suggestive of ascending cholangitis. 42 These patients require 4 fluids, antibiotics, and bile duct drainage, usually by endoscopy. See chapters 65, 66, 67, and 70. SBO intestinal obstruction is a common cause of abdominal pain in both the developed and developing WORLD22 and occurs in patients of all ages. In pediatric patients, intussusception, congenital malformations such as malrotation and Meckel diverticulum are the most common causes. 43 In adults, about 70% of cases are caused. Table 11.3 Causes of acute abdominal pain in patients presenting to an emergency department. Cause % nonspecific abdominal pain 35 Appendicitis 17 Bowel obstruction 15 Urologic disease 6 Biliary disease 5 Diverticular disease 4 Pancreatitis 2 Medical illness 1 Other 15 From Irvin T.T. Causes of abdominal pain in 1,190 patients admitted to a British surgical service. BRJSURG 1989, 76:1121-5. Table 11.4 The Alvarado score for predicting acute appendicitis. Feature points: migration of pain 1 anorexia 1 nausea 1 tenderness in RLQ 2 rebound tenderness 1 elevated temperature 1 leukocytosis 2 left WBC shift 1 sum 10. A score of 5 to 6 is suggestive of appendicitis, a score of 7 to 8 indicates probable appendicitis, and a score of 9 to 10 indicates that appendicitis is likely. Patients with scores greater than or equal to 5 should be evaluated by a surgeon or undergo an imaging study to look for appendicitis. From Alvarado A practical score for the early diagnosis of acute appendicitis. An Emergency Med 1986, 15:557-64. Chapter 11 Acute abdominal pain 153:11 By postoperative adhesions, incarcerated hernias, IBD, and malignancies make up most of the remainder. 44,45 SBO is characterized by sudden, cramping, periumbilical abdominal pain. Nausea and vomiting occur soon after the onset of pain and provide temporary relief of discomfort. Physical examination reveals an acutely ill, restless patient. Fever, tachycardia, and signs of volume contraction, including orthostatic hypotension, are common. Abdominal distension is common but may be difficult to discern in the setting of obesity. Although auscultation in patients with SBO is frequently thought to be characterized by hyperactive bowel sounds and audible rushes, these signs are unreliable. 17 The patient's abdomen may be diffusely tender to percussion and palpation, although the physical examination may be unremarkable even in the presence of visceral distress. Peritoneal signs should be considered a sign of intestinal ischemia or perforation. Leukocytosis and lactic acidosis suggest intestinal ischemia or infarction. Plain films of the abdomen are diagnostic when they reveal dilated loops of small intestine with air fluid levels and decompressed distal small bowel and colon. 46 Plain abdominal films can be misleading in a patient with proximal jejunal obstruction, because dilated bowel loops and air fluid levels may be absent. CT is superior for establishing the diagnosis and location of intestinal obstruction. The presence of reduced bowel wall enhancement in the setting of other findings of SBO significantly increases the probability of strangulation. A lack of free abdominal fluid significantly decreases the probability of strangulation. 47 Other findings, such as a transition point, are not reliable predictors of ischemia or the need for intervention. 47 In patients with SBO who have reassuring physical examinations and laboratory findings, initial treatment is with bowel rest, 4 fluids, nasogastric decompression, and close observation. 48,49 For patients with SBO who are admitted for a trial of non-operative management, many centers administer 120 ml of dilute imaging contrast material by mouth or nasogastric tube. The appearance of the contrast in the cecum within 12 hours predicts resolution of obstruction. 50 Surgery is required for patients who fail conservative management or have evidence of complete obstruction, especially if ischemia is suspected. but patients with adhesive SBO require surgery in fewer than 20% of cases. See Chapter 123.48,50. Acute diverticulitis. Acute diverticulitis is a common disease. Approximately 80% of affected patients are older than 50 years of age. 51. The overall incidence of the disease has increased by as much as 50%, with an even greater increase in younger persons. 52,53. Patients with diverticulitis usually present with constant, dull LLQ pain and fever. They may complain of constipation or obstipation and are usually found to have a leukocytosis. Physical examination demonstrates LLQ tenderness and, in some cases, a LLQ mass. Localized peritoneal signs are frequent. In severe cases, generalized peritonitis may be present, making differentiation from other causes of a perforated viscus difficult. CT is reliable in confirming the diagnosis, with a sensitivity of 97%, and should be performed routinely in the emergency evaluation of patients with diverticulitis. Acute diverticulitis presents as a spectrum of disease from mild abdominal discomfort to gross fecal peritonitis, which is an acute surgical emergency. The severity of diverticulitis, as determined by CT, is best described using the Hinchey grading system. See Table 121.2 in Chapter 121. Patients with mild disease and no CT findings of perforation, in the absence of limiting comorbid disease, can generally be treated as outpatients. Those with Hinchey grade I diverticulitis, localized pericolic abscess or inflammation, frequently require hospitalization for 4 antibiotics. Patients with Hinchey grade II diverticulitis, pelvic, intra-abdominal, or retroperitoneal abscess, should undergo CT-guided drainage of the abscess and receive a course of broad-spectrum 4 antibiotics. Patients with Hinchey III, generalized purulent peritonitis, and 4, generalized fecal peritonitis, diverticulitis frequently require emergency surgery. See Chapter 121. Despite the descriptive utility of grading systems for diverticulitis, there is little evidence to support their predictive value in deciding between surgical and medical management. 55 Patients presenting with significant abdominal pain or tenderness benefit from early surgical consultation. Acute pancreatitis. Hospital admissions for acute pancreatitis in the USA seem to be increasing. 56 Acute pancreatitis typically begins as acute pain in the epigastrium that is constant, unrelenting, and frequently described as boring through to the back or left scapular region. Fever, anorexia, nausea, and vomiting are typical. Patients with pancreatitis are usually more comfortable sitting upright, leaning forward slightly. Physical examination reveals an acutely ill patient in considerable distress. Patients are usually tachycardic and tachypneic. Abdominal examination reveals hypoactive bowel sounds and marked tenderness to percussion and palpation in the epigastrium. Abdominal rigidity is a variable finding. In rare patients, flank or periumbilical ecchymoses, Gray-Turner or Cullen sign, respectively, develop in the setting of pancreatic necrosis with hemorrhage. Extremities are often cool and cyanotic, reflecting underperfusion. WBC counts of 12,000 to 20,000/mm3 are common. Elevated serum and urine amylase levels are usually present within the first few hours of pain. Serum lipase is also elevated. Depending on the cause and severity of pancreatitis, serum electrolyte, calcium, and blood glucose levels and liver biochemical test and arterial blood gas results may be abnormal. US is useful for identifying gallstones as a potential cause of pancreatitis. CT is reserved for patients with severe or complicated pancreatitis. 57 Although most cases of acute pancreatitis are self-limited, as many as 20% of patients have severe disease with local or systemic complications, including hypovolemia and shock, renal failure, liver failure, and hypocalcemia. A number of prognostic physiologic scales, e.g., the SOFA and Apache 2 scores, have been advocated as measures of the severity of acute pancreatitis. 58 The Ranson score, first published in 1974, remains a useful and widely used checklist for the early assessment of patients with acute pancreatitis. 59 The Ranson score consists of 5 early and 6 late factors that indicate severe pancreatitis. See Table 58.2. A simpler bedside index of the severity of acute pancreatitis, BISUP, consisting Table 11.5 Tokyo criteria for the diagnosis of acute cholecystitis. A. Local signs of inflammation. Murphy sign RUQ mass, tenderness, or pain. B. Systemic signs of inflammation. Fever, elevated C-reactive protein, elevated WBC count. C. Imaging findings characteristic of cholecystitis. Definite diagnosis, one item in A and one item in B or C, when acute cholecystitis is suspected. Clinically adapted from Hirota J., Takada T., Kawurata Y., ETAL. Diagnostic criteria and severity assessment of acute cholecystitis, Tokyo Guidelines. Hepatobiliary pancreat SURG 2007, 14:7882. 154 Part 3 Symptoms, Signs, and Biopsychosocial Issues of Blood. Urea nitrogen greater than 25 mg/dl, impaired mental status, systemic inflammatory response syndrome, age older than 60 years, and pleural effusion, has also proved useful. 60 The Atlanta classification system for acute pancreatitis has great utility for bedside decision-making. 61 Patients without organ failure or local or systemic complications are classified as mild and may be treated expectantly. Moderately severe acute pancreatitis is typified by organ failure of less than 48 hours duration. When organ failure persists for more than this time, or affects multiple organ systems, severe acute pancreatitis is present. Patients in this last group usually require multidisciplinary care in an intensive care unit. A minority of patients with severe acute pancreatitis present with a profound intra-abdominal catastrophe, usually caused by thrombosis of the middle colic artery or right colic artery, which travel in proximity to the head of the pancreas, with resulting colonic infarction. This process may not be seen clearly on CT obtained early in the course of disease and should be suspected in any case marked by rapid hemodynamic collapse. Such patients require immediate laparotomy, see Chapter 58. Perforated peptic ulcer. As many as 4 million people worldwide are affected by PUD. Of these, as many as 5% present with perforation. 62 The epidemiology of PUD is changing, see Chapter 53. The incidence of HP infection has decreased dramatically since the late 1990s. 63 The overall incidence of PUD has declined by as much as half, and the number of patients requiring hospital admission for severe and complicated PUD has also decreased. 22 Improved therapeutic modalities, including PPIs, eradication of HP, see Chapter 52, and endoscopic methods for control of hemorrhage, see Chapter 20. Have reduced the number of patients with PUD who require surgical intervention. 64. Although the frequency of complicated disease has increased in older adults, in whom morbidity and mortality related to surgery are also increased. 65 The author's anecdotal experience suggests that the switch from opioids to NSAIDs in response to the epidemic of substance use disorder has resulted in an increasing frequency of perforated PUD in younger patients. Patients with a perforated peptic ulcer typically present with the sudden onset of severe diffuse abdominal pain. These patients may be able to specify the precise moment of the onset of symptoms. In the usual case, the afflicted patient presents acutely with excruciating abdominal pain, often without prodromal symptoms. Abdominal examination reveals peritonitis, with rebound tenderness, guarding, and abdominal muscular rigidity. In such cases, distinguishing perforated ulcer from other causes of a perforated viscus, e.g., perforated colonic diverticulum, perforated appendicitis, may not be possible. Older or debilitated patients may present with less dramatic symptoms, with perforation identified by the presence of free intraperitoneal air on an upright abdominal film or CT. A perforated peptic ulcer should be suspected in any patient with the sudden onset of severe abdominal pain who presents with abdominal rigidity and free intraperitoneal air. Pneumoperitoneum is detected on an abdominal film in 75% of patients, Fig. 11.7. In equivocal cases, CT of the abdomen usually suggests the diagnosis by demonstrating edema in the region of the gastric antrum and duodenum, associated with extraluminal air. CT may not be diagnostic, however, and patients with diffuse peritonitis or hemodynamic collapse should be explored surgically. Laparotomy is acceptable as the primary diagnostic maneuver in such patients. Endoscopy is not advisable when the diagnosis of a perforated peptic ulcer is suspected. Insufflation of the stomach can convert a sealed perforation into a free perforation. Survival following emergency surgery for complications of PUD is surprisingly poor. Implementation of evidence-based practice modeled on the surviving sepsis guidelines in Denmark reduced the 30-day mortality rate from 30% to 25% in patients with a perforated peptic ulcer. 66 The 2-year mortality rate in these patients was over 40%. See also Chapter 53. Acute mesenteric ischemia. Acute mesenteric ischemia can result from occlusion of a mesenteric vessel as a result of an embolus, which may emanate from an atheroma of the aorta or cardiac mural thrombus, or primary thrombosis of a mesenteric vessel, usually at a site of atherosclerotic stenosis. Embolic occlusion had accounted for up to 50% of cases of mesenteric ischemia in the 1980s, but, because of advances in the management of risk factors for embolization, accounts for no more than 1/3 of cases in the 2010s. It most commonly affects the superior mesenteric, presumably because of the less acute angle of the superior mesenteric artery origin from the abdominal aorta. 67 Atherosclerotic stenosis of the mesenteric vessels can result in primary arterial thrombosis. Patients usually have a history of atherosclerotic disease, particularly in the coronary or cerebrovascular circulation. Primary thrombosis now accounts for up to 68% of cases of mesenteric ischemia. 67 Non-occlusive mesenteric ischemia results from inadequate visceral perfusion and can also lead to intestinal ischemia and infarction. Such cases are usually consequent to critical illnesses like cardiogenic or septic shock. Non-occlusive mesenteric ischemia, also referred to as low-flow mesenteric ischemia, accounts for 10% of cases. The remaining 10% of cases of mesenteric ischemia result from venous thrombosis, usually associated with a thrombophilia, and focal segmental ischemia of the small intestine. See Chapter 118. Because most cases of mesenteric ischemia occur in patients with significant cardiovascular comorbidities, outcomes are poor. Perioperative mortality ranges from 50% to nearly 100%. 67,68 The hallmark of the diagnosis of acute mesenteric ischemia is the abrupt onset of intense cramping, epigastric and periumbilical pain out of proportion to the findings on abdominal examination. Other symptoms may include diarrhea, vomiting, bloating, and melena. On physical examination, most patients appear acutely ill, but the presentation may be subtle. Shock is present in about 25% of cases. CT angiography is the best initial diagnostic test for suspected acute mesenteric ischemia. Mesenteric angiography may be useful for determining the cause of intestinal ischemia and defining Fig. 11.7 upright chest film of an 80-year-old man with the acute onset of severe epigastric pain demonstrating free intra-abdominal air under the right hemidiaphragm. The patient has pneumoperitoneum as a result of a perforated viscus. At surgery, perforation of an anterior duodenal ulcer was found. Chapter 11 Acute abdominal pain. 155.11 The extent of vascular disease, however, CT has largely replaced formal angiography in these cases. Patients with acute embolic or thrombotic intestinal ischemia should be referred for immediate revascularization and bowel resection. 69 Patients with non-occlusive mesenteric ischemia are best managed by treatment of the underlying shock state. For patients with persistent symptoms, laparotomy for resection of infarcted intestine may be necessary. Transcatheter vasodilator therapy may be helpful for patients who are found to have vasospasm on visceral arteriography. See Chapter 118. Abdominal aortic aneurysm. Rupture of an abdominal aortic aneurysm, AAA, is heralded by the sudden onset of acute, severe abdominal pain localized to the midabdomen or paravertebral or flank areas. The pain is tearing in nature and associated with prostration, lightheadedness, and diaphoresis. If the patient survives transit to the hospital, shock is the most common presentation. Physical examination reveals a pulsatile, tender abdominal mass in about 90% of cases. The classic triad of hypotension, a pulsatile mass, and abdominal pain is present in 75% of cases and mandates immediate surgical intervention. 69 In patients with a suggestive history, emergency department use is a reliable method for the diagnosis of AAA in patients in shock and is sufficient evidence for emergency intervention. Endovascular methods for repair of an AAA have resulted in improved outcomes, although the short-term mortality rate is 40%. 70 Patients with suspected rupture of an AAA require urgent vascular surgery consultation to maximize the probability of survival. Abdominal compartment syndrome. Although not usually presenting as acute abdominal pain, abdominal compartment syndrome, ACS, warrants consideration in any patient with an abdominal emergency. First reported in the setting of massive intra-abdominal trauma, ACS, defined as pathologic elevation of intra-abdominal pressure, is now recognized as a frequent complication of many severe disease processes. 71 The peritoneal cavity normally has a pressure of 5 to 7 mm Hg, it may be higher in obese persons. 72 An elevated intra-abdominal pressure may develop in a patient who survives massive volume resuscitation with resulting visceral edema or who has a disease like severe pancreatitis that can cause visceral or retroperitoneal edema. Intra-abdominal hypertension, IA, is defined as abdominal pressure of 12 mm Hg or higher. 71 Elevation of intra-abdominal pressure that compromises visceral perfusion defines ACS. The kidney is particularly prone to underperfusion in this setting, and renal failure may be the first sign of ACS. 73 Primary ACS is defined as ACS that arises from pathology within the peritoneal cavity, such as gastric distension or edema from acute pancreatitis. 71 More common is secondary ACS, in which massive bowel wall edema secondary to shock is responsible for IA. A third form, tertiary ACS or recurrent ACS, results from overzealous attempts at abdominal wound closure after management of primary or secondary ACS. 72 Risk factors for ACS are listed in box 11.1. Intra-abdominal pressure can be measured simply by connecting a transducer to a urinary catheter, with the zero reference point at the mid-axillary line in a supine patient. An international consensus conference has established a grading scheme for ACS, shown in Table 11.6, based on the measured bladder pressure. 74 A normal value for bladder pressure is less than 7 mm Hg. Grade I ACS is defined as a pressure of 12 to 15 mm Hg, Grade 2 is 16 to 20 mm Hg, Grade 3 is 21 to 25 mm Hg, and Grade 4 is greater than 25 mm Hg. Non-surgical options for treating low-grade ACS include gastric decompression, sedation, neuromuscular blockade, placing the patient in a reverse Trendelenburg position while allowing the hips to remain in a neutral position, and diuretics. In a patient with high-grade ACS, particularly when renal or respiratory function is compromised, laparotomy with creation of an open abdomen is most effective. 75 Management of the open abdomen requires specific surgical expertise usually found in referral medical centers. Fortunately, the frequency of ACS has declined substantially in the 2000s, owing to increased awareness of the syndrome and advances in resuscitation. 72,76 Other intra-abdominal causes. Other intra-abdominal causes of acute abdominal pain include gynecologic conditions, e.g., endometritis, acute salpingitis with box 111. Risk factors for intra-abdominal hypertension and abdominal compartment syndrome. Abdominal surgery, especially with tight facial closures. Acidosis, pH 7.2, acute pancreatitis. Bacteremia. Coagulopathy, platelets 55,000/mm3, or activated partial thromboelastin time twice normal or higher, or prothrombin time 50% INR 1.5, damage control. Laparotomy. Distended abdomen. Gastroparesis, gastric distension, or ileus hemiperitoneum/pneumoperitoneum. High BMI, greater than 30 kg/m2, hypothermia, core temperature 33 degrees Celsius, intra-abdominal infection/abscess, intra-abdominal or retroperitoneal tumor, laparoscopy with excessive inflation, pressures, liver dysfunction/cirrhosis with ascites, major burns, major trauma, massive fluid resuscitation, greater than 5L of colloid or crystalloid/24HR, massive incisional hernia repair, mechanical ventilation, multiple transfusions, greater than 10 units of packed red blood cells/24HR, peritoneal dialysis, peritonitis, pneumonia, prone positioning, sepsis, use of positive end expiratory pressure, PEEP, or the presence of auto-PEEP volvulus adapted from Malbrain MNG, Cheetham M., Kirkpatrick A., ETAL. Results from the International Conference of Experts on Intra-Abdominal Hypertension and Abdominal Compartment Syndrome. I definitions. Intensive Care Med 2006, 32:17-22-32. Table 11.6 Grading System for Intra-Abdominal Hypertension * Grade Bladder Pressure, mmHg, normal 12:1 to 15:2 16 to 23 21 to 25 4 greater than 25 * Abdominal compartment syndrome is present if intra-abdominal hypertension is accompanied by organ dysfunction. Adapted from Carr J.A. Abdominal compartment syndrome, A Decade of Progress. JAM Call SURG 2013, 216:13546. 156 Part 3 Symptoms, Signs, and Biopsychosocial Issues or without tubo-ovarian abscess, ovarian cysts or torsion, ectopic pregnancy, SBP, Chapter 93, Functional Dyspepsia, Chapter 14, Infectious gastroenteritis, Chapters 110 to 112, Viral hepatitis and other liver infections, Chapters 78 to 84, Pyelonephritis, cystitis, mesenteric lymphadenitis, IBD, Chapters 115 and 116, and other bowel disorders such as IBS, Chapter 122, and intestinal pseudoobstruction, Chapter 124. Vascular compromise of an epiploic appendage due to axial torsion can result in epiploic appendigitis. 77,78 This syndrome can imitate appendicitis, diverticulitis, or other pathologies but has a self-limited natural history and usually requires only symptomatic management with NSAIDs. 78 The diagnosis is best confirmed by demonstration of an inflamed ovoid fatty mass adjacent to a non-inflamed segment of the colon on CT. 79 Extra-abdominal and systemic causes. Acute abdominal pain may arise from disorders involving extra-abdominal organs and systemic illnesses. Examples are listed in box 11.2. Surgical intervention for patients with acute abdominal pain arising from an extra-abdominal or systemic illness is seldom required except in cases of pneumothorax, empyema, and esophageal perforation. Esophageal perforation may be iatrogenic, result from blunt or penetrating trauma, or occur spontaneously, Baer-Have syndrome, see Chapter 45. Angioedema is characterized by acute, self-limited edema of the dermis, subcutaneous tissue, mucosa, and submucosa. The edema may affect the skin of the face, usually around the mouth, tongue, throat, extremities, and genitalia. Involvement of the GI tract may cause acute episodes of colicky pain, sometimes accompanied by nausea, vomiting, and diarrhea. Mast cell-mediated angioedema, often caused by allergic reactions to foods, drugs, or insect stings, is characterized by urticaria, flushing, pruritus, throat tightness, bronchospasm, and hypotension. Bradykinin-induced angioedema is not associated with these symptoms, has a more prolonged course, and is less clearly associated with an identifiable trigger, although angiotensin-converting enzyme inhibitor therapy is a known cause. Bowel wall angioedema can be seen in patients on angiotensin-converting enzyme inhibitors and in those with hereditary or acquired deficiency or dysfunction of C1 inhibitor and can be visualized on abdominal US or CT. Treatment of an attack depends on the acuity and severity and may include airway and hemodynamic support, discontinuation of potential triggers, antihistamines, glucocorticoids, and, in cases of hereditary angioedema, use of purified C1 inhibitor concentrate, a kallikrein inhibitor, and a bradykinin B2 receptor antagonist. Special circumstances. Extremes of age. Evaluation of acute abdominal pain in patients at the extremes of age is a challenge. Historical information and physical examination findings are often difficult to elicit or are unreliable. Similarly, laboratory data may be misleadingly normal in the face of serious intra-abdominal pathology. For these reasons, patients at the extremes of age are often diagnosed late in the course of the disease, thereby resulting in increased morbidity. For example, the perforation rate for appendicitis in the general population averages 10% but exceeds 50% in infants. The presentation of acute abdominal conditions is highly variable in these populations, and a high index of suspicion is required. A carefully obtained history, thorough physical examination, and high index of suspicion are the most useful diagnostic aids. In the pediatric population, the causes of acute abdominal pain vary with age. In infancy, intussusception, pyelonephritis, gastroesophageal reflux, mechal diverticulitis, and bacterial or viral enteritis are common. In children, mechal diverticulitis, cystitis, pneumonitis, enteritis, mesenteric lymphadenitis, and IBD are prevalent. In adolescents, pelvic inflammatory disease, IBD, and the common adult causes of acute abdominal pain predominate. In children of all ages, two of the most common causes of pain are acute appendicitis and abdominal trauma secondary to child abuse. In the older adult population, biliary tract disease accounts for almost 25% of cases of acute abdominal pain and is followed in frequency by nonspecific abdominal pain, malignancy, intestinal obstruction, complicated PUD, and incarcerated hernia. Appendicitis, although rare in older patients, usually manifests late in its course and is associated with high morbidity and mortality rates. Box 112 Extra-abdominal and systemic causes of acute abdominal pain: cardiac endocarditis, heart failure, myocardial ischemia and infarction, myocarditis, thoracic empyema, esophageal rupture, Barré-Have syndrome, esophageal spasm, esophagitis, pleurodynia, Bornholm disease, pneumonitis, pneumothorax, pulmonary embolism and infarction, hematologic acute leukemia, hemolytic anemia, Hainox-Schönlein purpura, sickle cell disease, metabolic acute adrenal insufficiency, Addison disease. Diabetes mellitus, especially with ketoacidosis, hyperlipidemia, hyperparathyroidism, hypersensitivity reactions, e.g., to insect bites, reptile venoms, lead poisoning, porphyria toxins, uremia, infections, herpes zoster, osteomyelitis, syphilis, typhoid fever, neurologic abdominal epilepsy, radiculopathy, spinal cord or peripheral nerve tumors, degenerative arthritis of the spine, herniated vertebral disc, tabes dorsalis, miscellaneous angioedema, familial Mediterranean fever, heat stroke, muscle contusion, hematoma, tumor, narcotic withdrawal, psychiatric disorders. Chapter 11 Acute abdominal pain 157 Pregnancy 11 The gravid woman with acute abdominal pain presents a difficult diagnostic dilemma. Acute appendicitis and cholecystitis develop in pregnant women at the same rates as in their non-pregnant counterparts. A number of additional diagnoses, such as placental abruption and pain related to tension on the broad ligament, must be distinguished from non-obstetric diagnoses. The risk of radiation injury to the developing fetus must be considered when imaging studies are planned. Surgery in pregnancy is not rare. Approximately 1 in 500 pregnancies will be associated with a non-obstetrical general surgical intervention. 80 Primary consideration is given to the health of the mother. Emergency interventions during pregnancy carry a risk of fetal loss that varies with gestational age and the type of intervention. The middle 3 months of gestation are preferable for abdominal surgical intervention. This period presents the lowest risk for teratogenicity and spontaneous labor. Appendicitis occurs in about 1 in 2,000 pregnancies and is equally distributed among the 3 trimesters. In later stages of pregnancy, the appendix may be displaced cephalad, with consequent displacement of the signs of peritoneal irritation away from McBurney point. In challenging cases, MRI may be useful for establishing a diagnosis in this setting. Biliary tract disease is also common during pregnancy. Open or laparoscopic management of these diseases is safe but is associated with adverse obstetrical outcomes in approximately 5% of cases. 81 Immunocompromised hosts. In addition to diseases like appendicitis and cholecystitis that occur in the general population, a number of diseases unique to immunocompromised hosts may manifest with acute abdominal pain, neutropenic enterocolitis, drug-induced pancreatitis, graft versus host disease, pneumatosis intestinalis, and CMV and fungal infections. See Chapter 36. Patients infected with HIV can present a particular challenge. See Chapter 35. When advanced, HIV infection is associated with a number of other diseases that may present as acute abdominal pain. One of the most common abdominal disorders seen in immunocompromised persons in the developing world is primary peritonitis. See Chapter 39. Affected patients have suppurative peritonitis without a definable source. Spontaneous intestinal perforation, usually secondary to CMV infection, is also common in patients with advanced HIV infection. TB peritonitis is a consideration in patients from areas where TB is common. 82 Immunocompromised patients may lack the definitive signs of an acute abdominal crisis usually seen in immunocompetent persons. Elevated temperature, peritoneal signs, and leukocytosis may be absent in these cases. Pharmacologic management. An unfortunate practice in the care of patients with acute abdominal pain is to delay administration of narcotics pending definitive surgical assessment. Sir Zachary Cope declared, "Morphine does little or nothing to stop serious intra-abdominal disease, but it puts an efficient screen in front of the symptoms." 83 The practice of delaying relief of pain in a suffering patient, however, does not appear to withstand careful clinical scrutiny. 6 studies in which early administration of analgesia was compared with administration of placebo in patients with acute abdominal pain have shown that patients who receive analgesics are more comfortable and do not experience a delay in diagnosis. 84,85 Patients with an acute abdominal process frequently require antibiotic treatment for peritonitis. When appropriate, antibiotic therapy aimed at the likely causative pathogens should be given as soon as a putative diagnosis is reached, but little benefit is derived from treating an immunocompetent patient with broad-spectrum antibiotics before a likely source is identified. Patients who are immunocompromised or neutropenic, however, should receive broad-spectrum antibiotics early in the course of management for acute abdominal pain.